4.
Yeah, Dr. Tunaggina Afrin, consultant, United Hospital. Dr.
Assalamualaikum, sir.
Tunaggina.
Am I audible, sir?
Walaikum salam. Tunaggina Afrin Khan.
Tunaggina, welcome to the presentation ceremony.
Thank you, sir.
Please.
Good afternoon. Assalamualaikum. I'm Dr. Tunaggina Afrin Khan from United Hospital. I present my case here. My patient, 59-year-old hypertensive diabetic and dyslipidemic lady, who presented with class 3 stable angina. At the time of presentation, she was hemodynamically stable with normal ECG and normal left ventricular ejection fraction. We did the coronary angiogram showing critical lesion in distal LAD. And borderline lesion.
Show us epicranial view.
In middle.
Middle one, yes. Yes. Go forward.
There is also mild stenosis noted in the mid part of the RCA and the distal part of the RCA. But what we observed was that there was a fall of blood pressure from 130 to 80 millimeter mercury to 110 to 60 millimeter mercury after engagement of the RCA ostium with 5 French catheter. So we decided to do PCI in LCX with DFR in LAD and RCA. We went to right radial approach. It was a 6 French XP guide catheter, and we put the DFR wire in LED. The DFR was significant. It was 0.8. Also, PD by P was also significant, less than 0.9. So the lesion in the LED was considered significant. So we proceeded for stenting the LED. The dilatation was done with 2.5 into 20 millimeter balloon at 214 atmospheric pressure. And we put drug-eluting stent. It was 3.5 48 millimeter drug-eluting stent. But after stenting of the LED, the big diagonal branch, it was the D2, got compromised. We tried to negotiate another BMW wire to the diagonal branch. And subsequently, after several attempts, we could recover the flow. But with careful look, we found that there is a dissection at the proximal stent strut, which probably occurred during pulling out the P-dilatation devices through the catheter, probably which occurred with the suction force of the guide catheter towards the LED stent struts. So we put another 3.5 into 16 millimeter drug-eluting stent covering the distal left main to LED. Actually, it's few strut, 1 or 2 millimeter struts in the distal left main, and we covered the LED. And post-dilatation was done with 3.5 into 15 millimeter, and then 4 into 15 millimeter balloon with high pressure. This is the view of the LED after stenting. Then we proceeded to stent the LCX. We took another wire in the LCX, and we took another balloon, 2.5 into 20 millimeter balloon. And then we put a 2.5 into 20 millimeter drug-eluting stent. And post-dilatation was done with the same stent balloon. But soon after the post-dilatation, the next scene, we could see there was shift of carina of LCX with the OM. As there was TIMI III flow, we left it as it was. And this is the view of LAD and LCX after revascularization. Then we proceeded for DFR. We took the preparation for doing DFR in the RCA, but soon after we engaged the RCA ostium with a 6-French catheter, there was significant fall of blood pressure. So we considered the ostial lesion significant in the RCA, and we didn't do the DFR. We directly went for PCI in the RCA. It was 3 into 15 millimeter balloon. We took different views to confirm that few of the stent struts stay out of the RCA ostium. And the stent was a 3.5 into 32 millimeter gravity stent. RCA was well revascularized. So my take-home message was seemingly harmless or borderline lesion may be functionally significant. So IFR, DFR, or FFR helps to take decision. And follow blood pressure during catheter engagement is an important indication for significant narrowing at the ostium. During pulling out of an inflation device, the guide catheter may be sucked into the main vessel and may cause proximal dissection. And shift of carina may occur. In main vessel ostium, like left main, it may be an important indication for bifurcation PCI. But in our case, there was a TIMI III flow in distal OM, so we left it as it was. And provisional one stenting technique is a viable option if the side branch is less than 2 millimeter diameter. I acknowledge my teacher, Dr. Kaisana Sir, Senior Consultant Cardiologist of United Hospital. And thank you.
Tunaggina, for your brilliant presentation. Now I introduce our co-moderator, Dr. Professor Khandaka Shohid, and he will take the charge for the next presenters. Before that, if any question, and anyone can be volunteer, ask any question.
I have one question, please.
Yes, sir.
So you did the LCX stenting after putting the stent covering the LAD ostium, yeah?
Yes, sir.
So in any case, if the ostium is a bit overhanging of the stent in the LAD ostium to left main, then it will be difficult to do the procedure to the LCX. So in that circumstance, yes. In that circumstances, I think, especially for the beginner, for fellows and juniors, better to do the LCX first, then put the stent covering the LAD ostium, isn't it?
Yes.
That is also a very good option. In our case, we just put 1 or 2 millimeter stent struts in the left main. Just we wanted to cover the LAD ostium actually to cover the dissection. So we thought it would not be a problem to stent the LCX at all. That was
so
our
2 millimeter definitively that will overhang the LCX ostium also, yeah.
yeah, the 1 or 2 stent struts probably.
Chance there, so there is every chance to difficulty to negotiate the stent LCX.
Moment, you're not audible.
Yes.
I totally agree with you. There is every chance to difficulty to negotiating the LCX stent. It may not be
Other
negotiable.
issues sometimes may happen. Other issues sometimes may happen. The pituitary struct may deform, leading to stent thrombosis and ISF.
Okay. Cool.
The most importantly, what I can say that go for the tightest most lesion, which was in the LCX. So do that one, and the later on go for the LAD. That is what the even the dissection is there. The TIMI III flow was there. So it's better to go for the LCX and then go for the LAD again. That would be the better thing, because otherwise anytime you may complicate the procedure and you will have another 2 stents to solve all the problems like here.
Thank you, Professor Saidur Rahman and Dr. Ashok. It is our regular practice what we are doing that you have told, but as because the case was done probably by N.M. Mominuzzaman, his expertise with his
Dr. Kaisar
Nasrullah Khan, and that is why probably they became over enthusiastic and they have done it.
No, operators,
Yes,
operators'
definitely.
choice is there. Obviously, operators'
considering
choice is
that it
there.
will create
Yeah,
new.
yeah.
Okay, next